Today, I'm Dr. Riya Gupta. Giving a presentation on Vortioxetine and its role in OCD. In this presentation, I have not highlighted what OCD is, but I have explained what Vortioxetine is, its mechanism of action, and the recent researches that have been done about its action and effect in OCD. So this is my index. I have explained about the classification of antidepressants, vortioxetine, mechanism of action, pharmacokinetics of vortioxetine, its effect in depression, vortioxetine in OCD, the summary and the references. So coming to what vortioxetine is, as far as the class of antidepressants is observed, vortioxetine comes under a serotonin modulator. So it's a newer class of drug. The vortioxetine belongs to serotonin modulators class of drugs. It is distinct from other classes of antidepressant. It is currently indicated in the treatment for major depressive disorder in adults. The initial dose is about 10 mg that is administered orally once a day without regard to meals. That is, the consumption of food does not have an effect on its absorption. Then the dose can be increased to up to 20 mg per day as tolerated by the patient. It inhibits the reuptake of synaptic serotonin, thereby increasing the level of serotonin in the bloodstream. Increased synaptic concentrations of 5-HT, that is serotonin, norepinephrine, dopamine, and acetylcholine. Thus, it contributes to the antidepressant effects and has the unique pro-cognitive properties in patients with major depressive disorder. Currently, it is most extensively studied with MDD. So as we can see in this table is that vortioxetine works on serotonin at 5-HT2A, 5-HT1B and D, along with 5-HT3 and 5-HT7 receptors. So it has multimodal action. It it works as an agonist at 5-HT3, 5-HT1A, as a partial agonist at 5-HT1B, as an antagonist at 5-HT1D, as an antagonist at 5-HT3, and again as an antagonist at 5-HT7. In vivo non-clinical studies, it has also demonstrated that vortioxetine enhances levels of serotonin, norepinephrine, dopamine, acetylcholine, and histamine in specific areas of brain, thereby providing an antidepressant and a pro-cognitive benefits. So let's come to its sertraline blockade. SERT blockade. So vortioxetine has high affinity for SERT, that is serotonin transporters, and SERT blockade increases the availability of serotonin in the synaptic cleft, as it has been demonstrated in the figure that the reuptake of there is blockade of the SERT, which increases our intrasynaptic levels of dopamine. Now coming to the activation of the autoreceptors, that is how it helps by increasing the serotonin levels, by how it helps in modulating the serotonin levels by the negative feedback mechanism. So the receptors that are present on the presynaptic nerve cells are basically the serotonin autoreceptors. It is a part of negative feedback loop, hence limiting the release of serotonin. That is why we say that it modulates the effect of serotonin. Here we are targeting the 5-HT1 presynaptic receptors, that are the somatodendritic autoreceptors, and also the 5-HT1D and 1B receptor. So coming to vortioxetine and its effect on the 5-HT1A receptor, where it acts as an agonist. As an autoreceptor, it acts as a brake on the serotonergic transmission. It acts as an agonist at the 5-HT1A receptor, which is an autoreceptor for serotonergic neurotransmission. The 5-HT1A receptor desensitizes over time. Desensitization of 5-HT1A increases serotonin release, and this is believed to assist in relieving depression. Coming to 5-HT1B, 5-HT1D, and 5-HT7 receptor blockade. The SERT inhibition and activation of the negative feedback mechanism, which further inhibits the release of 5-HT. And the SERT inhibition combined with the stimulation of the 5-HT1A receptor and partially or fully blocking the 5-HT1B and D and 5-HT7 receptors, leading to the enhanced release of 5-HT, enhanced release of serotonin, again explaining the serotonin modulating effect at the 5-HT receptor mediated regulation of acetylcholine and norepinephrine. Serotonin stimulation of 5-HT3 receptor causes inhibitory output from the GABAergic interneurons, which inhibits the release of norepinephrine and ACH from the presynaptic nerve terminals. So when whereas SSRIs increase serotonin levels by SERT inhibition, GABA is released, which in turn inhibits both norepinephrine and acetylcholine. When in comparison with vortioxetine, the vortioxetine blocks 5-HT3 receptors so that GABA is not released by 5-HT, and therefore both norepinephrine and ACH are disinhibited, that is, their levels are enhanced. So these are all the activities that happens due to the vortioxetine. So 5-HT1A, it acts as an agonist, that is postsynaptic 5-HT1A receptors that inhibits the GABAergic interneurons, which favors the release of glutamate, not NA, dopamine, ACH, and histamine in the prefrontal cortex. At 5-HT1B, as it acts as a partial agonist that blocks the postsynaptic 5-HT1B heteroreceptors, and there is partial agonism of the postsynaptic 5-HT1B heteroreceptors that in turn increases the release of acetylcholine, norepinephrine, dopamine, and histamine, and it also increases the release of glutamate in the hippocampus and the prefrontal cortex. At 5-HT3 antagonism, it blocks the 5-HT3 receptors that inhibits the GABAergic interneuron, which is in itself inhibitory and there is release of glutamate is favored in the hippocampus and the prefrontal cortex. So coming to the pharmacokinetic profile, one of the most important thing is the effect of food. There is no effect of food on its pharmacokinetics. That is, we can take it both on empty stomach and on full stomach. So the Tmax is reached within 3 to 16 hours. The bioavailability is of about 75%. The steady state concentration is reached within 2 weeks. That is the effect. Its full effect can be seen within 2 weeks. The plasma protein binding lies within a range of about 80% to 90%. The terminal half-life is about 60 to 70 hours. It is metabolized primarily by the cytochrome P450 isozymes by CYP2D6. The maximum recommended dose is of 10 mg per day in known CYP poor metabolizers. Reduce the dose by 1/2 when the patients are receiving CYP2D6 strong inhibitors such as bupropion, fluoxetine, paroxetine, or quinidine concomitantly. There is no clinical significant differences in the exposure of vortioxetine were observed based on the age, gender, ethnicity, renal function, or hepatic function. Coming to the real-life effectiveness of vortioxetine in depression, that is a relief study. It was a 24-week observational prospective cohort study in the OPD patients with MDD. Initially, treatment with vortioxetine was given. The primary study outcome was patient functioning assessed by the SDS score, that is the Sheehan Disability Scale. Secondary output included depression severity based on a 9-item patient PHQ-9 questionnaire, cognitive symptoms on PDQ-D5, and cognitive performance on DSST. A total of 737 patients were eligible for inclusion in the full analysis set, out of which 73.7% patients reported at least one comorbid medical condition, and 56% had comorbid anxiety and 24.4% had comorbid GAD. So the key findings in this study included that there was meaningful improvement in the STS total score, which was experienced by almost 2/3 of all patients after 12 weeks. They assessed it after 12 weeks of vortioxetine treatment, and by approximately 3/4 after 24 weeks, improvement in the severity of the functional impairment and work productivity measures. There is clinical meaningful improvement which was seen across functioning and all the other effectiveness outcomes in patients receiving vortioxetine as the first-line therapy for the current MDE and in those who have received one or more prior antidepressants for current MDD. Greatest improvement was seen when vortioxetine itself was used as a first-line treatment. Now, I have highlighted some of the specific studies that have been recently done when we have used vortioxetine in OCD. So a study was done by Basilis et al., which was published in 2025, which is an original research paper which titled The Efficacy and the Tolerability of Vortioxetine Monotherapy in SSRI-Resistant OCD, a retrospective multi-center study. SSRI-resistant OCD is something where an appropriate dose of SSRI has been given for the adequate amount of time. The primary objective was to evaluate the effectiveness and the tolerability of vortioxetine when used as a monotherapy for adult patients with OCD who did not respond to the standard treatment with SSRI. The study was a retrospective observational analysis methodology and the participants. The researchers analyzed the clinical records of about 64 patients who were diagnosed with OCD as per DSM-5. All the patients had previously failed in at least one trial of an SSRI, indicating that they were treatment resistant. The Vibox was assessed after 8 weeks of treatment with vortioxetine, and secondary outputs included change in depression and anxiety symptoms, which were assessed by again HAM-E and HAM-D scores respectively. The study administered vortioxetine at a minimum dose of 20 mg per day for 8 weeks. The average dose was about 25.9 and 6 patients received a higher dose, about 40 mg per day. So the key findings included that the study was found that 39.1% of the patients met the criteria for being a responder, which means that they showed a clinically significant improvement. There was a significant reduce in the Vibox score, indicating a reduction in the OCD symptom severity. There was also improvement in the anxiety and the depressive symptoms, and vortioxetine was generally well tolerated, and the most common side effects were nausea and sedation, and no serious adverse effects were documented here. Coming to another study, which was done by Fernandez et al., published in 2024, titled as the use of vortioxetine in treating OCD. It was a case report wherein they discussed a study of a 48-year-old male with a history of OCD, has again failed for SSRI treatment, and there was also a contraindication in this patient for TCA due to a recent MI. The findings included 10 weeks of vortioxetine treatment, reduction in OCD and depressive symptoms. HDRS scale dropped from 21 to 4. Vibox also showed reductions in across various compulsions. The patient did not experience any sexual dysfunction, which was a common side effect for previous medications. The article concluded that vortioxetine may be a promising treatment option for OCD patients who cannot use typical first and second line treatments. The Berardis et al. Published a study again in 2017, wherein they used both vortioxetine and aripiprazole for a patient with treatment-resistant OCD with comorbid MDD. So there was up to a 70% reduction in the Vibox scale. The depression symptoms also were reduced. They approximately used a dose of vortioxetine to about 20 mg per day alongside aripiprazole. Aripiprazole was used approximately to a dose of 5 mg per day along with a maximum dose of 20 mg per day of vortioxetine. There was also, I have again reported one more study of efficacy and the safety profile of vortioxetine as an add-on molecule in OCD. Here we are using vortioxetine as an adjuvant. A randomized double-blind placebo-controlled study was done by Sucharita Mandal et al. And published in 2025. It included 114 patients who were subjected to vortioxetine and escitalopram and were of OCD. 114 patients individuals diagnosed with OCD who met the criteria as per DSM-5 and ICD-10. So now here they divided it into two groups, the experimental group and the control group. Experimental group with vortioxetine and escitalopram, control group had placebo with escitalopram. They assessed them at a schedule of 4, 8, and 12 weeks via using the respective clinical scales. Escitalopram in both the groups was started at 10 mg. After 10 days, the dose was increased to 20 mg. Vortioxetine in the experimental group began with a dose of 5 mg. They were titrated up to 10 mg by day 10, and the dose was maintained for the remainder of the trial. The control group will be received a matching placebo. Vibox was applied to evaluate the OCD symptom severity along with the clinical global impressions and the adverse events and side effects checklist was also used for monitor and document any side effect. The trial's unique clinical significance was that the trial's unique design using a placebo plus escitalopram control group allows the researchers to specifically determine the incremental benefit of adding vortioxetine to a standard OCD treatment. The findings of this trial were intended to help and optimize the personalized treatment plans for individuals with OCD. Coming to the summary, that vortioxetine is firstly a serotonin modulator. It acts as an agonist in 5-HT1A, partial agonist in 5-HT1B, and an antagonist in 5-HT3 and at 5-HT7. It works by autoregulation at the presynaptic membrane and inhibits the inhibitory GABAergic interneuron, which thereby increase the norepinephrine and the acetylcholine. It is well studied for depression. However, few studies are available for the OCD. It can be used as a monotherapy where SSRI have previously failed. Works best at a dose of 20 mg per day. Has minimal sexual side effects which were seen with other SSRI. It can also be used as in conjunction with aripiprazole, wherein aripiprazole can be given at a dose of 5 mg, increased up to 10 mg, and vortioxetine at 10 to 20 mg can also be given in combination with escitalopram up to a maximum dose of 40 mg. Reduces both Vivox, HAM-D, and HAM-A scores. It relieves obsessive, depressive, and anxiety symptoms as well. More studies are required to understand the role of vortioxetine, and the roles appear to be positive and in OCD and TRD as a monotherapy as well as an adjuvant. These are my references. Thank you so much.